Regarding the infected total hip replacement surgery, infection risk is about 0.5% in osteoarthritis and raises to 1% in rheumatoid arthritis. The deep surgical infection rate is 0.57 in hip replacement and 0.8% in total knee replacement. Most common infective organism is Coagulase negative Staphylococcus, followed by Staph aureus, Enterococci, and Streptococci. Coagulase negative Staph aureus. Coagulase negative Staphylococcus. Regarding taking the patient, I will take optimal history, review the index operation, revision surgery, any blood transfusion which done, any delay with wound healing, hematoma formation, any hip debridement done, washout done during the index procedure. I will like to know pain-free period of the patient, recurrent infections like UTI and dental extractions, or upper respiratory tract infection. Regarding the pain, I would like to know the site, duration, and progression of the pain. Nocturnal pain is important. Septic osteolysis, where the pain has persisted for more than the time of operation, is continuously relentless, progressive, and the patient has rest pain or night pain. It can occur in the well-functioning arthroplasty from a distant source where there is a hematogenous spread, for example, dental procedure, respiratory or urinary tract infection. Risk factor, skin condition is important, permeability of bacteria, psoriasis, peripheral vascular disease, comorbidities like diabetes mellitus, chronic kidney disease, immunocompromised, liver failure, malnutrition, HIV. Inflammatory arthropathy like rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. Morbid obesity, more than 50%, has 18% increased risk of periprosthetic joint infection. This is by Parvizi et al., 2010. Smoking, excessive alcohol consumption, IV drug abuse, and poor oral hygiene. Can do serum to continent test for smokers. Recent bacteremia should be excluded. On examination, patient should be examined. A gait should be assessed. Previous surgical scar should be assessed. A circumferential examination or signs of infection or induration is important, and deformity or contractures. Regarding some important classification, a Coventry and Fitzgerald classification is important. Acute is less than 3 weeks and chronic is more than 3 weeks. Chronic means superficial infection, infected hematoma, not invading prosthesis itself, it's hematogenous. Chronic can be more than 3 weeks, low-grade infection, and biofilm formation can happen. Regarding another classification is Parvizi classification, which is MSIS, Consensus Meeting Criteria 2018. One major or more than 5 minor is diagnostic. Javed Parvizi and Associate. Major criteria: presence of sinus tract with communication to the joint or visibility of prosthesis. Number 2, more than 2 positive cultures at separate samples. So any of this one is present, the patient is infected. Now talk about the minor criteria. If the patient scores more than 6, it's infected. More 2 to 5 is inconclusive. 0 to 1, not infected. Serum. CRP more than 10 mg per liter or D-dimers more than 60 nanogram per milliliter. 2 points. ESR more than 30 millimeter per hour. 1 point. Then synovial. In synovial, WBC count more than 3000 cells per microliter. 3 points. Positive alpha defensin. 3 points. Synovial PMN count more than 70%. 2 points. Synovial CRP more than 6.9 milligram per liter. 1 point. Intraoperative diagnosis: more than 6 infected, 5 inconclusive, and 0 to 1 less than 3 not infected. Positive histology 3 points, positive purulence 3 points, 1 positive culture 2 points. Biofilm is basically produced by bacteria Staphylococcus, formed by implant within 3 weeks of infection. It's a polysaccharide glycocalyx layer protecting bacteria from host immune system. Adhere to the foreign material, inhibit antimicrobial activity, and reduce antibiotic penetration. Antibiofilm agents: rifampicin for gram-positive and ciprofloxacin for gram-negative bacteria. Organisms: Staph aureus 20, Coagulus negative Staph aureus and Staph epidermidis 30%, Peptostreptococci in dental procedures. Fungal infection: Canada require antifungal drugs for 6 to 12 months. Regarding the investigation, I will do CRP. It goes as more than 250 in first week post total hip replacement surgery. Peaks at 3 days. More than 10 milligram per deciliter is positive. Sensitivity 88% and specificity 74%. ESR up to 6 months to go back to normal. Sensitivity 75% and specificity 70%. ESR of more than 30. Interleukin 6 produced by monocytes and macrophages peaks at 2% and rapidly goes down. Sensitivity 97% and specificity 91%. Interleukin 6 is more accurate than ESR, CRP, or WBC count, as Barbary et al. 2010. Synovial Shore is alpha-defensin test for periprosthetic joint infection. Synovial Shore is 97% sensitive, 96% specificity, and only 62% in low-grade infection. It can be false positive in metallosis. PCR can have amplified bacterial DNA count. Synovial fluid count more than 3000 cells per microliter, more than 80% PMN, and CRP more than 3.6. If you can aspirate and it's dry, you can do saline injection and re-aspiration. A patient should be off antibiotics for 2 weeks. Histopathological analysis: at least 7 samples should be taken. Intraoperative section: 10 WBC per high power field. X-ray osteolysis, cortical destruction, newborn formation, periosteal reaction. Technetium bone scan: sensitive, useful. If negative, can remain positive for 2 years, within 2 years of total hip replacement surgery. White cell scan: specificity 100% but low sensitivity 45%. Positive emission tomography: sensitivity 98%. Regarding the management, if there is a sinus, I will inject ethylene blue. Ethylene blue will give the sinus tract. In acute case, within 6 weeks, a DAIR, debridement, antibiotic, and implant retention is advisable. Success rate is 16 to 89%. The important factor is that the bacteria should be of low virulence and known microorganism. Patient not immunocompromised. The other option would be to have the antibiotics should be taken for at least 6 weeks. The other option will be prosthetic removal, antibiotic spacer placement, and then continuation of antibiotic for 6 weeks. 2 types of spacer: ALAC and Prostalac. Aim of spacer is maintain joint space and reduce dead space, and antibiotic dose is given in around the area. Increase porosity by hand mixing instead of vacuum. Heat stable antibiotics are utilized. Gentamicin, maximum dose 10 gram. Mostly we give 80 milligram multiplied by 3 is equal to 240 milligram. Tobramycin 2.5 to 3.6 gram per 40 gram package of cement. 2 weeks elution time. Vancomycin 1 to 4 grams, maximum 10 grams. The gentamicin has 6 weeks elution time and tobramycin has 2 weeks elution time. Duncan and Musri 2009, two-stage revision arthroplasty of hip for infection with prostalac hip spacer. At mean follow-up at 12 years, success of 89%. Causative organism was identified pre-operatively for single-stage disease. Single-stage reduced the cost and reduced stiffness. Chronic infection caused by epidermidis or propionine bacterium has high recurrence rate and with retention, and two-stage revision should be considered. Bestwick from Bristol, no difference in 1 to 2 stage revision surgeries in longitudinal studies. Excision arthroplasty in cases with recurrent infection, good pain and relief. Suppressive antibiotics for unfit patients. What you do if there is 5 consecutive total hip replacements which are infected. Number 1, stop all operation. Number 2, make sure that the patients who have infection are appropriately treated. Assess patients that might be infected. Root cause analysis with the MDT approach. Entire patient pathway should be checked. Treatment in root cause analysis will include infectious disease doctors, theater managers, theater engineers, and ward managers.